Hello everyone. So in this video I am going to explain the second part of the hematology. So let's start. So hemolytic anemia. Hemolytic anemia means that there is breakdown of the blood. Lytic means lysis, means breakdown. So there is breakdown. Hem means blood. So there is breakdown of blood. Now hemolytic anemia may be two types. It is due to it may be intracorpuscular or extracorpuscular. Intra means inside, means there is defect within the RBC. So intracorpuscular means defect in the RBC, and extracorpuscular means extra means outside. So there is defect other than the RBC. Now what were the causes of the intracorpuscular hemolytic anemia? So the causes may be membranous, acquired hemoglobin deficiency, or there is enzyme deficiency. So these were the causes of intracorpuscular hemolytic anemia. So let's do the hereditary spherocytosis, which is a type of membranous cause, So in the hereditary spherocytosis, the most common mutation is, so in hereditary spherocytosis, most common mutation is ankylin. Please remember it. Don't say that spectrin is the most common cause. So most common mutation in hereditary spherocytosis is ankylin. So this is a structural membrane protein. So as the defect in the ankylin, if there is any mutation in the ankylin protein, then the membrane gets stabilized. So how the pathogenesis occurs? So suppose this is a normal RBC. This is a normal RBC. Now if there is mutation in the ankylin, then the membranes become unstable, because ankylin and spectrin, they both stabilizes the membrane. Now the mutation in ankylin, it means the membranes become unstable. So if the membrane become unstable, means there is loss of water from the red blood cells. So there is loss of RBC, loss of water from the RBC, and the RBC size gets converted into a spherical shape. So RBC shape converted into a spherical shape. So as it becomes the spherical shape, so we called it spherocytes. And as the spherocytes passes through the spleen, so spleen has a very narrow blood vessels. So as they passes through them, then they get phagocytosed by the macrophage, and macrophage get engulf the red blood cells. In this way, extravascular hemolysis occur. So in this way, extravascular hemolysis occur in the hereditary spherocytosis. And as I told that there is increase in MCHC only and only in the hereditary spherocytosis. Increase MCHC value only and only in the hereditary spherocytosis. Now what is the clinical features? So there is one tried for the hereditary spherocytosis. So tried for hereditary spherocytosis, there is anemia due to breakdown of red blood cell. There is anemia. Now as the engulf more and more macrophages engulf the red blood cells in the spleen, so the size of spleen gets enlarged, so the splenomegaly will occur. And there is also jaundice is occur in the hereditary spherocytosis. So for the triad of hereditary spherocytosis, we have to remember three things. First one, anemia, splenomegaly, and there is jaundice. Now crisis of, if there is crisis, then it leads to hemolytic crisis or aplastic crisis. In the aplastic crisis means all the cells were less in number, means there is bone marrow suppression will occur. There is bone marrow suppression will occur in the aplastic crisis. And what is associated with aplastic crisis? So aplastic crisis is associated with parvovirus B19. Please remember that parvovirus B19 is associated with aplastic crisis. Now what is the diagnosis we can do in hereditary spherocytosis? So first one, we do the peripheral smear. So on the peripheral smear examination, we find all the red blood cells in the oval shape. As we see here, all the red blood cells in the spherical shape, that is spherocytes. So as we see these, so it means this is a spherocytes, means it is found in either in the hereditary spherocytosis, either in the G6PD deficiency, or it can be found in the autoimmune hemolytic anemia. So spherocytes were found in the hereditary spherocytosis, G6PD deficiency, or they can also found in the autoimmune hemolytic anemia. And please remember that spherocytes were the most common cause of spherocytes is autoimmune hemolytic anemia. So most common cause of spherocytes. So the most common cause of spherocytes is autoimmune hemolytic anemia. Please remember it. It is very important questions. So most common causes autoimmune hemolytic anemia, and spherocytes were seen in three conditions. First one is the hereditary spherocytosis, second is G6PD deficiency, third one is autoimmune hemolytic anemia. Second, in the diagnosis we do the osmotic fragility test, OF test. We do the osmotic fragility test, and in the hereditary spherocytosis, H means high, means osmotic fragility is increased in the hereditary spherocytosis. Normally the RBC get isotonic with 0.9% NaCl, but here they get lysis at 0.5% NaCl. Normally they were isotonic at 0.9% NaCl, but here because their osmotic fragility is increased, so they get lysis at 0.5% NaCl. So in this we see that the normal they are isotonic with 0.9% NaCl solution, but here they start lysis at 0.5%. As we see here, they start lysis at 0.5%. So please remember it. And what is the treatment for hereditary spherocytosis? As in this there is splenomegaly is occur, and everything is because of the spleen, because all the macrophages were present in the spleen, and the macrophages engulf the red blood cells from the spleen. So for the treatment we do the splenectomy. So for the treatment of hereditary spherocytosis we do the splenectomy. Please remember it. So this is all about the hereditary spherocytosis. Now let's move to the elliptocyte. So in the elliptocytes we study about the acanthocytes and the echinocytes. So acanthocytes, as we see in this peripheral smear, so they look like a spike like red blood cells. So RBC have the spikes. So these RBC have the spikes. And in the echinocytes, as we see in the RBC, there is regular projection, means there is regular projection, or we can remember it like E for echinocytes and E for equal, means the projections were equally from all the surface, and acanthocytes means they were spike like. So as for spike and as for spur cells, so spur cells were seen in the acanthocytes, because in acanthocytes we see, as we see here, we look like these are the spikes coming from the red blood cells. So these were the spikes, and as for spike, as for spur cells, and A for acanthocytes, and this is seen in the example is A beta lipoproteinemia. A for acanthocytes and A for A beta lipoproteinemia. Now in the echinocytes, as we know, their equal projections were coming from all the sides of the surface of RBC. So as we make the E, we can make it like a B. We can make it like a B, means Burr cells. So in the echinocytes, we see the Burr cells. And for the example, as we write the Burr, B stands for Burns and U stands for uremia. B stands for Burr and U stands for uremia. So these were the examples of Burr cells, and A beta lipoproteinemia is found in the A beta lipoproteinemia we found the acanthocytes. Now next one is the G6PD deficiency, that is a enzyme deficiency. So in G6PD deficiency, as we all know that if there is deficiency of G6PD, then it is a protection against P. falciparum. Please remember that G6PD deficiency is a protection against the P. falciparum. So the persons who have the deficiency of this enzyme, it means they already get protected from the P. falciparum. Now what is the pathogenesis? So normally the G6PD, glucose 6-phosphate dehydrogenase, they protect our body from via HMP pathway. Why HMP pathway? That is hexose monophosphate pathway. And G6PD, it neutralizes the free radicals. Example H2O2. So G6PD neutralizes the free radical, that is H2O2. And if there is deficiency in G6PD, means there is increased level of H2O2, means there is oxidative stresses occur. Means if there is, because G6PD prevent us from the free radicals. So if G6PD is deficient, means free radicals were increased. So as the free radicals were increased, means the H2O2 level is going to increase in our body, means there is oxidative stress will occur. So on the peripheral smear, what we see? So on the peripheral smear, as we see these here, that a blue dot is present outside the red blood cells. A blue dot is present. So this is a hinge bodies. Why we see hinge bodies in the G6PD deficiency? Because as the H2O2 level is increased, so they denature our hemoglobin. So hinge bodies consist of denatured hemoglobin. So hinge body consists of denatured hemoglobin. And in the second, as we see here, bite cells were seen. So in the G6PD deficiency, we also see the bite cells. So as we see here that some part is got bite by the macrophages. So bite cells were seen in the G6PD deficiency, and hinge bodies were also seen in the G6PD deficiency. So this is about the G6PD deficiency. Now there is one note about that is episodic and chronic. So episodic is intermittent, while chronic is not associated with splenomegaly, while episodic is intermittently associated with splenomegaly. So if there is episodic means suddenly there is G6PD deficiency or suddenly there is splenomegaly will occur, then what were the precipitated causes? So the causes were the due to infection, due to fava beans, or due to a drug that is anti-malarial drug, that is primaquine. So infections, fava beans, and anti-malarial drug, that is primaquine. So these were the precipitated causes. Now next one is PNH, that is paroxysmal nocturnal hemoglobinuria. So basically what will happen in this the person when the person wake up in the morning, and then when he passes his urine, he see blood in the urine. So hematuria were seen by the person. So this is presentation of PNS, that is paroxysmal nocturnal hemoglobinuria. Now in this, what is the defect? So there is piga gene deficiency is there, and due to which there is CD55 and CD59 complement system is not regulated by these proteins, that is CD55 and CD59. And CD55 is a DAF, DAF, and CD59 is MIRL. So they were GPI anchors. So their function of CD55 and 59 is to regulate the complement system. So they regulate the complement system. So if so as in the night, if there is deficiency of CD55 and 59, so if in the night, as the respiratory rate is decreased, so decreased respiratory rate, then the acidic pH is also decreases, so complement system gets activated. So as the complement system gets activated, then as here is CD55 and 59 is deficient, then RBC breakdown starts. This leads to hemoglobinuria. But if the CD55 and 59 is present, then they regulate this complement system, and it does not let the RBC to break down. So that's why if there is deficient, then it lead to RBC breakdown and hemoglobinuria is present. So this is the clinical presentation, and this is the causes of the PNH. Now what were the tests we do for the PNH? So for the screening test, we do the sucrose lysis test, or we can also do the HAMS test. While for the confirmatory, we do the flow cytometry, because we have to check the CD59 and 55 marker. So as CD55 and 59 is both were absent, then it is a suggestive of PNH. Now what were the complications? So complication of PNH lead to either it lead to leukemia, there is overproduction, or it can also lead to aplastic anemia. So due to bone marrow suppression. So now next move to the hemoglobinopathy. So in the hemoglobinopathy, first one is the sickle cell anemia. So first one is sickle cell anemia. So in the sickle cell anemia, as we all know that it is a autosomal recessive condition. As for the autosomal recessive, we remember the trick, that is pasta chawal, and in which S stands for sickle cell anemia. So it is a autosomal recessive condition, and in this sickle cell anemia we have the point mutation, that is a missense mutation. So at what point there is point mutation? So at the place of G beta, at the beta 6 chain, at the 6th position, glutamic acid is going to convert into valine. How we can remember that glutamic is converted into valine, or valine is converted into glutamic acid? So we can remember like glutamic means go, G for go, G for go means glutamic acid gone, and valine is for welcome, and there is welcome of valine. So in the place of glutamic acid there is valine comes. So this is a point mutation in the sickle cell anemia. Now the normal adult hemoglobin is represented by HbAA, and sickle cell anemia is represented by HBSS, and if the representation is HBAS means it is a carrier of sickle cell. Now as HBA is oxygenated and HBS, in the HBS there is decreased level of oxygen, means it is deoxygenated hemoglobin. So as the hemoglobin is deoxygenated, so in sickle cell anemia S stands for sickle, S stands for sticky, and there is solubility decrease. So sticky, solubility decrease, and sickle. So as the solubility is decreased and the blood cells become sticky, so there is occlusion of the blood vessels will start. So whatever the clinical features were present, as the occlusion will start, so first condition is vaso-occlusive crisis is there. Vaso-occlusive means there is occlusion of the blood vessels and so many blood RBC get occluded there. So it is seen in the skull, in the vertebra, in the digits, in the lungs, and in the spleen it is seen. So in the skull we see a crew cut appearance, or we can also say a hair on end appearance or crew cut appearance. In the vertebra, fish mouth vertebra is present. In the digits, hand foot dactylitis is seen. In the lungs, acute chest syndrome is seen. While in the spleen there is autosplenectomy is seen, as the size of spleen get decreased due to loss of blood supply. So as we see here the skull, it represents some hairy like structure, that is a hair on end appearance, or we can also say a crew cut appearance, which is seen in the sickle cell anemia, and also it is seen in thalassemia. Please remember that when we see this image, we did not diagnose directly that it is a sickle cell or a thalassemia, because both can be present. Either it is a sickle cell anemia condition or either it is a thalassemia. We have to look further investigation. We have to do further investigation that it is a thalassemia or it is a sickle cell anemia. And in the vascular occlusive crisis, as we see here, there is a sickled cells were seen. Now as the first one is the vascular occlusive crisis is there. Second one is sequestration crisis, means all sickle cells are sequestered in spleen. All sickle cells were sequestered in spleen. Third condition is aplastic crisis. Aplastic crisis means there is bone marrow suppression, which is due to parvovirus B19. Means there is in aplastic crisis means there is decreased RBC, WBC, and platelets. All levels were get decreased. What were the diagnosis of sickle cell anemia? So diagnosis, first we do the peripheral smear, and in peripheral smear we see the sickled RBC. We see a sickled RBC as we see here. These were looking like a sickled RBC. Now second test, we do the sickling test. In sickling test we use a 2% sodium metabisulfate. So we use 2% sodium metabisulfate for sickle cell anemia diagnosis. Third one is we check the ESR value, and in the sickle cell anemia there is decreased ESR, as the ESR stands for erythrocyte sedimentation rate, and in this there is reduce of ESR. And fourth one is the hemoglobin electrophoresis. We do the hemoglobin electrophoresis, and as the normal hemoglobin, it moves towards the anode, as A stands for adult hemoglobin, and it moves towards the anode. Well, the carrier is partial, as in the carrier HBA and S both were present, means adult one move towards the anode part and S does not move. So and in the HBSS, when the person is sickled, when the person has sickle cell anemia, in that person HBSS is present and they does not move towards the anode side. So in this, the HBSS, it only stands towards the cathode side. HBS, how we can remember? S for slow, means slow hemoglobin is present, means it is towards the cathode. While in the A stands for adult hemoglobin and A stands for anode, means it move towards the anode side. Next one is the HPLC, means we do the high performance liquid chromatography. In the high performance liquid chromatography, as it is a gold standard for hemoglobin disorders. It is a gold standard for hemoglobin disorders. Now what is the treatment we do for the sickle cell anemia? So for the treatment, we have to increase the oxygen level, because in sickled hemoglobin there is decreased oxygen level. So for the treatment we have to increase the oxygen. So how we can increase the oxygen? By giving a hydroxyurea, that is increase because in hydroxyurea there is presence of fetal hemoglobin, and as we all know, fetal hemoglobin get more oxygen. Fetal hemoglobin contains the more oxygen. Now this is the treatment of hemoglobin oxygen. So next one is our thalassemia. So in that thalassemia there is deficiency, either there is deficiency of alpha chain or there is deficiency of beta chain. If there is deficiency of alpha chain, we called it alpha thalassemia, and if there is deficiency of beta chain, we called it beta thalassemia. So in alpha thalassemia there is decreased level of alpha, and in beta thalassemia there is decreased level of beta chain. Now due to gene deletion, so in alpha thalassemia it is due to gene deletions, while the beta thalassemia is due to gene mutation, and most commonly we found the gene mutation is there, means most commonly beta thalassemia is present. So as the adult hemoglobin HbA has the 2 alpha and 2 beta chains, and alpha chains were present on chromosome number 16 while the beta chains were present on chromosome number 11. Please remember it that the alpha chain is present on chromosome number 16 while the beta chain is present on chromosome number 11. Now first we do the beta thalassemia. There is beta thalassemia and beta chain is present on chromosome number 11, and it is basically due to mutation. So the most common mutation in beta thalassemia is splicing mutation. So most common mutation in beta thalassemia is splicing mutation. Now what were the types of beta thalassemia? So for the types of beta thalassemia, we have beta thalassemia major, beta thalassemia minor, and beta thalassemia intermediate. So what were the others name? So beta thalassemia major is also known as transfusion dependent or Cooley's anemia Either we can say beta thalassemia major, transfusion dependent, or we can say Cooley's anemia. These were the three names of the beta thalassemia major, while the beta thalassemia minor were transfusion independent and they were known as beta thalassemia trait, BTT, that is beta thalassemia trait. So first we do the beta thalassemia major. So in the beta thalassemia major there is decrease of beta chain, means the alpha, there is lot of alpha chain aggregation. As the alpha chain gets aggregated, so the RBC gets breakdown. So there is lysis of RBC because ineffective erythropoiesis. Due to ineffective erythropoiesis there is RBC breakdown, means anemia will occur. So anemia, as the anemia will occur, so there is repeatedly we have to do blood transfusion. That's why other name for beta thalassemia major is transfusion dependent. So for the compensation there is increased iron absorption also, and by this there is iron overload is going to occur in beta thalassemia major patient. Iron overload is seen in the beta thalassemia major patient, and there is repeated blood transfusion. That's why other name for beta thalassemia major is transfusion dependent. Now for the diagnosis, what we can do, for the diagnosis we see there is microcytic hypochromic anemia, target cells were seen, and on the peripheral smear we find these three findings. First one is the microcytic hypochromic anemia. The size of RBC is lesser than the normal size, and the color also, they were more paler in the center, and the target cells were seen as they look like a target cell, and basophilic stippling is also seen in the beta thalassemia major. And second, we find there is increase of fetal hemoglobin level is increased in beta thalassemia. So these were the findings of beta thalassemia major. Now let's discuss about the beta thalassemia minor, that is transfusion independent, or we can say beta thalassemia trait, versus iron deficiency anemia. So how we can we are going to discuss between the beta thalassemia minor and iron deficiency anemia. So thalassemia, first one is the Menger index. So in the Menger index, how we calculate it? We calculate it like this: mean corpuscular volume upon my red blood cells, mean corpuscular volume upon my RBC. This is the formula for Menger index. And in the beta thalassemia, as the name suggests, less, means Menger index is less than 13. As in the spelling of the thalassemia, less is coming, so it means that Menger index is less than 13, while in the iron deficiency Menger index is more than 13. This is the first point of differentiation between beta thalassemia minor and iron deficiency anemia. Second one, the adult HbA2 hemoglobin is more than 3.5% is found in these conditions. Now let's move to the alpha thalassemia. So in the alpha thalassemia, the cause is gene deletion, while in the beta thalassemia gene mutation is there, and in alpha thalassemia gene deletion is there. So normally alpha 4 alpha genes were present. So normally 4 alpha genes were present. If there is deletion of one alpha gene, so it is asymptomatic. If there is alpha dash present, means alpha thalassemia trait is there. And if there is only one alpha is present, alpha dash and dash is there, then it is a HBH disease. And on the microscopic examination, we find the golf ball inclusion. Please remember it. Golf ball inclusions were seen in HBH disease. And if there is no alpha gene is there, then it is known as hemoglobin Bart's disease, HB Bart's disease. And in this, the birth is stillbirth. In this, birth is stillbirth if there is deficiency of all the alpha genes. Now, what is the screening test? So for the screening test, please remember it, Nesterov is done. Please remember it, Nesterov. N stands for naked eye, and naked, E stands for eye. So there is naked eye. S means single, T means tube. Single tube is there. R means red cell, O means osmotic and fragility. So by the naked eye, in the single tube, red cells were seen and osmotic fragility we have to check. And in the thalassemia, as the name suggests, less incoming, so in this osmotic fragility is going to reduce. Osmotic fragility is going to reduce in thalassemia. So as we see a naked eye osmotic fragility, we can do osmotic fragility test by naked eye. So as suppose this is a normal red blood cells is present in this tube. So as we see, all the lines were visible in this, means RBC breach, all the lines were visible. Well, in this means the RBCs were intact to each other, and we did not see any lines, means breaching is not seen in this, means this is a patient of alpha thalassemia. This is a patient of thalassemia. As L stands for lines and A means absent, means lines were absent. We did not see the line in the Nesterov test. So this is a blood is present, and we have to, how we can check this? So normally we took a tube and a blood of the patient is present in it, and we add 0.35% NaCl. So normally blood cells get lysis at this, but in the thalassemia, the red blood cells were intact with each other, and they does not show any visible line because the red blood cells were intact to each other. Please remember it. In the thalassemia, we did not see any lines, so lines were absent. And how we can remember? As we write the thalassemia, L stands for lines and A stands for absent, means we did not see the lines. So this is a osmotic fragility test. And for the confirmatory, we do the HPLC. Now the extracorpuscular defect. So in the extracorpuscular defect, we have to study about the autoimmune hemolytic anemia and microcytic microangiopathic hemolytic anemia. So AIHA and MIHA. First we do the AIHA, that is autoimmune hemolytic anemia. So it may be warm autoimmune hemolytic anemia or cold autoimmune hemolytic anemia. So warm is due to because immunoglobulin G is present at 37 degrees Celsius. Example is CLL. Well, for the cold autoimmune hemolytic anemia, the reasons were mycoplasma or malignancy is there, and there were two types: cold agglutinin disease or cold hemolysin disease. So in cold agglutinin disease, IgM is more common than the cold hemolysis disease. IgG were seen, which is also known as Donath-Landsteiner antibody. So IgG is Donath-Landsteiner antibody. While in the cold agglutinin disease, IgM is there. And we see that they get agglutinated in the peripheral smear. RBC were agglutinated. That's why it is autoimmune hemolytic anemia. Now next one is the microangiopathic hemolytic anemia, means MIHA, that is microangiopathic hemolytic anemia. Micro means small, angio means blood vessels defect. There is pathy is there, means small blood vessel defect is there. So as we see here, they were the normal red blood cells, and due to a thrombus they get fragmented. So RBC get fragmented, which is also known as cystocytes, So for the example of MIHA, we have example is HUS, that is hereditary hemolytic uremic syndrome, TTP thrombotic thrombocytopenic purpura, and DIC, disseminated intravascular coagulation. So these were the example of MIHA, means small blood vessels defect. Due to small blood vessel defect, there is fragmentation of red blood cells is going to occur, which is fragmented RBC is known as cystocytes. Fragmented RBC is known as cystocytes, and example of MIHA is HUS, TTP, and DIC. I hope this is you get benefit of this video and you get some knowledge from this video. Thank you. Bye bye guys.